Yeah, yeah, yeah.
Okay, Yole. Only this one, number one. We've checked it straight, but after all, right love one. 1, 2, 3, 4, 5. 1, 2, 3. Meant to switch it on. 1, 2, 3, 4, 5. Sound check 1, 2, 3. Yeah, 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 yeah. 1, 2, 3. 1, 2, 3. Kunjani lo? None. Okay. Uh, yeah. Ngehlisa. 1. Yeah, yeah, yeah. 1, 2.
Ed, we want to do them all together, please, okay? What number is this? Okay, now. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 10, 10, 10. Morning. 1, 2, 3, 4, 5, 10. Ruben, do you want to put another one on? What's wrong, Red? Switch them all on at the same
Yes,
time.
we want
Yeah,
to
okay,
check
that's a
them
good idea.
all. Then we see
Okay.
any crash.
Testing 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 5, 6, 7, 8, 9, 10. Reg, there's maybe a bit too much gain on this one, right? Please. Because that
Right,
popping is.
Lobu. 1, 2, 3.
This is number 4. 1, 2, 3. Number 4. Number 4. It says 4 on the body pack.
three,
Dirk,
four.
how's that camera sound for you? 1, 2. Dirk's happy.
One,
Mike,
Yeah.
where's your mic?
3, 4, 5,
He
6.
gave it back to me.
1, 2, 3, 4, 5,
Okay.
Sorry, I thought.
7.
1,
1, 2,
2.
3.
Okay.
All
One,
right,
two,
we're
four.
good.
Question and answers, we're good.
Yeah.
1, 2,
Is there
3,
going to
4,
be
5.
Reggie? Just listen if there's any feedback close to the speaker. No, we're
1,
good.
2.
Sound.
Oh,
Check.
that's
1, 2,
lovely.
3.
That's great.
Okay,
Yeah.
great.
Yeah,
1, 2,
yeah,
3,
yeah.
4,
1,
5.
2, 3, 4, 5, 6, 7, 8. 2, 4.
Happy with the audio on the stream?
Happy,
Happy
boss?
with the audio on the stream?
Years ago, yeah, no,
7, 8.
1 2 1 2 1 2 1 2 1 2 1 2 1 2 1 2 1 2 1 2 eyes fam 1 2 1 2 1 2 1 2 1 2 1 2 Japan make one make an Nikren level wise no Japan no pass nothing no pass no pass is awuna pass 1 2 1 ankuluma I think we fire good line angafaka uline izoba nepass then ingakhatha anytime kanjalo Japan on red ngithi yakhe pass yakhe empage itlin happiness okay sharp ngicela okay sharp
Then once it goes raised, you'll be live. And you can talk. And then when you're done, yes.
One.
Morning, everyone. Can you hear me? The back? Good, thank you. All right, good morning. On behalf of the Health Market Inquiry panel, it's my pleasure to welcome you all here this morning to the media briefing and release of the Provisional Findings and Recommendations report. My name is Clint Ullerman. I'm the Inquiry Director. A special word of welcome to the Honourable Minister of Health, Dr. Aaron Matsuleri, the Competition Commissioner, Temenkosi Bonakele, and his Deputy Commissioner, Ardeen Ratchisusu. And of course, welcome to all of you here today that have taken time out of your busy schedules to attend the briefing. We're also live streaming this event this morning, so it's available on our website. There's a link on our website, so stakeholders that weren't able to be here this morning are able to follow the proceedings. Unfortunately, one of our panel members, Dr. Kees van Gent, isn't here today. He couldn't be with us, but he is watching the live stream from Amsterdam this morning. So good morning and welcome to you, Kees. Today is the 5th of July, marks a very important milestone for the Health Market Inquiry. It's of course the release of our provisional report. It's the culmination of 4 years of work which the panel and technical team have now put together into the report. The inquiry is acutely aware of the eagerly anticipated release of this report, and I think it's evident by the turnout here today and the number of inquiries that we've received during the course of the build-up to today. In terms of today's program, I'm going to hand over to the panel chair shortly, who will give the address on behalf of the panel. The chair will take you through the inquiry process. He will give an overview of the provisional findings and recommendations, also highlighting some of the challenges that we faced along the road to the provisional report. The chair will also announce the comment period for the submissions and responses to the provisional report and lay out the process going forward, what we expect from stakeholders and what we expect to hear from you. Once the chair has concluded his address, we'll open up the Q&A session for stakeholders and journalists. That will be facilitated by Sipho Ngwema, the spokesperson and the head of communications for the Competition Commission. We will then formally close the briefing, but we'll allow some time for journalists after we've closed to approach the panel and take further questions and answers. Just finally, the provisional report, I'm sure you all want to know when that will be available. The full report will be accessible on our website later this afternoon. As I'm speaking to you now, we are uploading the executive summary, the summary of the recommendations chapter of the report, and the panel chair's address, which should be up on the website in the next minute or so. So I'm going to hand over to the panel chair now, retired former Chief Justice Sandile Ngcobo, to give his address. Thank you. Judge.
What is that? This? Oh, good morning, ladies and gentlemen. It's a great pleasure to be here this morning. All that we are going to do today is no more than announce the fact that we've published the provisional report. It does seem to me that that's all I should be telling you. But if one has a look at this turnout, it does seem to me that I need to say more than just telling you that the report will be available. Otherwise, you'll be very angry with me. The purpose of coming here today is really to announce the publication of our provisional findings and preliminary recommendations, which are contained in our provisional report. This announcement, of course, will be utterly incomplete without highlighting our key provisional findings and preliminary recommendations. But perhaps to put the provisional report in context, let me refer briefly to the background to the investigation and remind you of our mandate, describe the process we followed in carrying out our mandate, and refer to some of the challenges that we have encountered in the process. And I think it is necessary to refer to these challenges because they simply underscore some of the recommendations that we are going to make. As most of you are probably aware, the Competition Commission initiated the health market inquiry after observing increases in prices and expenditure in the private healthcare sector, which had reached the level which only a minority of South Africans could afford. This observation prompted the Commission to inquire into and evaluate explanations for observed increase in prices and expenditure in the private healthcare sector. The Commission wanted the inquiry to establish whether there are any factors that prevent or restrict competition in the private healthcare sector, and to establish information that would provide a factual basis upon which the Commission can make recommendations to promote competition in the interest of a more affordable, accessible, innovative, and good quality healthcare. It was against this background that the Commission appointed a panel of independent experts to conduct the health market inquiry into the state of competition in the private healthcare sector. The panel's mandate was set out in the terms of reference, which were published in the Government Gazette. I think it was on the 29th of November, 2013. It's been a long time ago. It is important, of course, to understand that the focus of our investigation is the private healthcare sector and not the public sector. While the inquiry has provided us with a window through which to see what's happening in the public sector, this report does not deal with the public sector. An inquiry into the cause of poor quality of healthcare services in the public sector is a question for another day. This inquiry focuses primarily on understanding the factors that prevent, distort, and lessen competition in the private healthcare sector. The terms of reference required us to establish a factual basis for recommendations that support the achievement of accessible, affordable, high quality, and innovative private healthcare in South Africa. The question of how to improve access to affordable and good quality healthcare has therefore been approached from a competition standpoint, while noting, of course, that the crucial issue of equitable and fair access to healthcare services doesn't rest entirely on competition. A comprehensive commission of inquiry into the state of healthcare in both the private and the public sectors may be more appropriate to evaluate the general state of healthcare services in South Africa in order to give effect to the constitutional right of access to healthcare services, which is enshrined in Section 27 of the Constitution. The statutory question that we are required to answer is whether there are features in the private healthcare markets for services and goods which harm competition or have a potential to harm competition. These features can take the form of structure or conduct or both of participants in the private healthcare sector, as well as poorly designed and implemented legislation, improper governance, and poor regulatory oversight. In answering this question, we had to comply with the principles of procedural fairness and transparency, which is a constitutional requirement. This, of course, required us to provide stakeholders sufficient time to engage with, review, and, of course, consider the information and analysis conducted by the inquiry that may, of course, adversely affect them. And it was in the light of these principles that the Health Market Inquiry published various reports and offered the stakeholders the opportunity to comment on these reports and granted them access to underlying data that we used in compiling these reports. Indeed, the very publication of the provisional report and the opportunity to comment on that report simply underscores that requirement of fairness. Now, what process did we follow? Broadly speaking, the inquiry process progressed through 4 phases: the establishment phase, evidence gathering, analysis of information and data, and the release of the provisional findings and preliminary recommendations report. The establishment phase, of course, involves setting up the platform for the inquiry process and initial engagement with stakeholders. These included the publication of the foundational documents for the conduct of the inquiry, such as the statement of issues, which indicated to the stakeholders the initial issues that were going to be the focus of the inquiry. And it also included the publication of the guidelines that were going to regulate the conduct of the inquiry. The evidence gathering phase had 4 constituent parts, which comprised conducting background research, calling for and receiving written submissions from stakeholders, requesting and receiving data from about 174 health stakeholders, including a request for financial data, as well as detailed claims data for the period running from 2010 to 2014, which we requested from about 80 medical schemes. And finally, it also comprised of public hearings and seminars on selected topics. The call for written submissions generated more than 15,000 pages of submissions, which largely consisted of technical data and information on various healthcare markets. Before these written submissions could be published for comment by other stakeholders, we had to consider several claims to confidentiality which were raised by a number of stakeholders. This was a time-consuming exercise indeed, but nevertheless, it was essential to the process. The third phase of the inquiry entailed the analysis of data and information collected. This ran concurrently with the second phase. Various models and base analytical processes were run to determine, among other things, expenditure and cost trend, profitability, and market power. The results from all of this analytical work, including the input of the technical team and panel members, formed part of comprehensive technical reports on a set of service providers, including descriptive statistic report, attribution analysis report, prescribed minimum benefit analysis report, and of course associated projects and various case studies. The fourth phase brings us here today with the publication of the provisional report. But the road to this phase has been punctuated by some challenges. And one of the greatest challenges was in the area of the identification of data sources, collection of data, and processing of information and data. And the importance of data for the purposes of the inquiry cannot be gainsaid. The terms of reference, for example, require the inquiry to inquire into factors that drive the observed increases in private healthcare expenditure and prices, to evaluate various explanations for such increases, and to identify competitive dynamics at play. Data is essential in determining trends in expenditure cost and profitability, as well as the explanation for the observed increases, in particular, whether these increases are due to the exercise of market power or some other anti-competitive conduct. The first challenge we faced is that there is no central and uniform data and information storage system pertaining to private healthcare in South Africa. The only sources of data are medical schemes, practitioners, hospital groups, and public data sources, including regulatory bodies. These stakeholders collect data and information for their own use with limited criteria and requirement for reporting in the sector. Secondly, we experience significantly long and sometimes cynical delays in the submission of data by stakeholders. This prolonged the process of data collection and included a number of engagements with lawyers representing various stakeholders. Thirdly, processing, collating, and storage of data presented its own challenges. We had to satisfy ourselves on the integrity and the quality of data. In addition, we had to ensure that data submitted were correct in terms of category and time series, that it was submitted in correct format, and that it was accurate and complete. In some cases, data had to be sent back to the submitting stakeholder in order to correct data sets or present data in the correct format. The integrity of data is crucial to the accuracy of our analysis. Fourthly, one of the issues of concern pertaining to data was the need to preserve confidentiality in respect of the data that we collected. The data, as you would have known, contained personal patient information which could not be disclosed. We therefore had to develop the identification tool that would ensure the removal of personal identifiers in all data sets in our possession. This process allowed stakeholders to provide us with data pertaining to patient information and addresses in a format that ensured that any information likely to identify as the various patients would not be made public, while at the same time keeping individual patients' records distinct for analytical purposes. This was also a very time-consuming exercise. The delay encountered in collecting, collating, and storage of data was exacerbated by the complexity of processing data into a format that can be used for analysis and the sheer volume of data that had to be processed. We collected approximately 545 gigabytes of data. The process involved data being compiled in a format from various diverse systems, making data complete and then organizing it into data set and warehousing these data sets has been an enormous task. But apart from this, certain stakeholders requested access to the underlying data of all the analytical reports published by the Health Market Inquiry over the duration of the inquiry. And in response, we had 3 separate data room periods to facilitate fair opportunity for stakeholders to comment on the analytical report. Such access to underlying confidential information was restricted to external advisors of stakeholders who wish to review the data and the workings of the inquiry. We have therefore made significant efforts to ensure that stakeholders were given adequate opportunity to conduct relevant verifications of analytical reports in the data room, whilst also ensuring that it complied with the commitments made to us by the data providers. Now, the lesson that we learned from this, in particular, the challenges encountered in the context of data collection and processing, underscore the urgent need to develop a comprehensive national information system which will require stakeholders to provide information relating to health financing, the pricing of healthcare services, business practices involving hospitals and healthcare providers, and the publication of various types of information in the public interest and for the purposes of improving access to healthcare and the effective and efficient utilization of healthcare services. All of this is contained in the National Health Act, and in due course, we will be urging the Department of Health to expedite the implementation of the provisions of the Act which deals with these matters. The significance of data in this market inquiry is amply demonstrated by the fact that the integrity of the data that we used, the methodologies that we used to analyze this data, as well as our application of these methodologies are heavily contested by the stakeholders. Now, before highlighting our key provisional findings and the preliminary recommendation, I wish to make a few general remarks. You will understand that the report runs to more than 800 pages, as I understand it. And what I'm going to try to do is really to condense these 108 pages to a manageable exercise that we can all understand what's contained in this report. Firstly, the South African private healthcare sector comprises a complex set of interrelated stakeholders that interact in markets that are not transparent and not so easily understood. Secondly, the South African private healthcare sector is part of a two-tier national system with a dual problem. The cost of private healthcare is high and rising, while public healthcare services are affordable but generally of poor quality. The public healthcare sector does not pose a significant competitive constraint to the private sector for patients or for service providers. The public sector is not a big purchaser of services from the private sector, and so, unlike in other countries, public sector tariffs do not influence what is charged in the private sector. Due to poor quality of facilities in the public sector, private patients are barely inclined to use the public sector, even if it is much cheaper. Thirdly, by and large, the market is characterized by high and rising cost of healthcare and medical scheme cover, highly concentrated funders and facilities markets, disempowered and uninformed consumers, a general absence of value-based purchasing, ineffective constraint on rising volume of care, practitioners that are subject to little regulation, and failures of accountability at many levels. Finally, the evolution of the market to its current form is the consequence of changing regulatory environment, which saw periods of deregulation in the late 1980s and then partial re-regulation, which has led to the status quo. The end result is that facilities are not regulated beyond the requirement to license to operate, and practitioners are licensed to practice by the Health Profession Council of South Africa, but nothing more. the funder that is on the demand side of the market is characterized by significantly more regulation, including open enrollment, community rating, and a prohibition of risk rating. However, the funder's regulatory regime is incomplete. The overall incomplete regulatory regime can largely be attributed to a failure in implementation on the part of the regulators and inadequate stewardship by the Department of Health over the years. We say this because some of the recommendations we have considered are already provided for in current legislation but have not yet been implemented. Now, I propose to address our key finding in 4 broad areas. I will first present our key findings on expenditure and supply-induced demand. The findings of supply-induced demand have not previously been published and will thus be new to the stakeholders. Thereafter, I will set out the key findings pertaining to funders, which include medical schemes, administrators, and brokers. And then I will move on to hospital and finally, the medical practitioners. Now, in its terms of reference for the inquiry, the Commission cited high and rising prices and expenditure as one of the key reasons for the initiation of this inquiry. One of the first tasks of the panel was thus to understand the factors that drive expenditure in the private healthcare sector. The analysis of the industry claims data provided us with an opportunity to quantitatively describe expenditure trends in the private healthcare sector. The data allowed us to identify what proportion of the claims cost can be explained by factors that are known to influence expenditure, such as age, gender, disease profile, and the severity of the medical condition the person is being treated for, which is known as a case mix. In our model, these are called explained factors. After identifying the explained factors, an unexplained portion of expenditure remains. Bearing in mind that we have done our utmost to identify all factors reasonably expected to drive healthcare expenditure, the portion that remains unexplained cannot easily be attributed to the illness or demographic features of the population. The claims analysis show that the Commission's initial concern with affordability and escalation of health care expenditure is well-founded. The inquiry collected claims data for the period stretching from 2010 to 2014. Now, over this period, the average expenditure per private medical scheme member increased by 9.2% per annum. After adjusting for factors such as inflation, age, members, plan type, gender, disease profile, and membership involvement, the unexplained factor increase in expenditure per member was still greater than 2% per annum in real terms. To put this in context, the 2% of spending amounts to around 3 billion rand in 2014 terms. That is 330 rand per beneficiary per annum that could not be explained by factors reasonably expected to drive expenditure. Most of this unexplained increase in claims costs can be attributed to in-hospital rather than out-of-hospital care, indicating a relative shift in claims costs towards hospital-based care that cannot entirely be attributed to the process of risk analyzed by the health market inquiry. the unexplained portion of in-hospital claims cost were also materially higher than out-of-hospital care. Unexplained factors accounted for 32% of in-hospital claims cost for open schemes, that is, those schemes that provide for open membership and accept all applicants as members, and 27% for restricted schemes, which are schemes that are restricted to specific applicants, such as employees of particular companies. Now, in comparison, for out-of-hospital care, only 16% of claims cost were unexplained for open schemes and 2% for the restricted schemes. The high proportion of unexplained claims cost increases for in-hospital care is concerning, and our findings suggest that this is in part due to high utilization, that is, a high number of admissions and increases in cost per admission. We therefore conducted further detailed analysis of the claims costs, focusing on practitioners, facilities, and funders. These reports were published in December last year, and the stakeholders engaged with them extensively. Given our findings on high unexplained increases in claims costs, the health market inquiry more closely evaluated the effect of increased utilization and the possible presence of supplier-induced demand in the private healthcare sector. The data suggests that there is indeed strong evidence of supplier-induced demand. Now, supplier-induced demand is a phenomenon by which increasing access stimulates additional use of the service that would not have otherwise occurred. So if there are more beds available, they can be used, and in healthcare, they will be used. Or the offer of more or another investigation or more treatment just to make sure, or just to be careful or to exclude anything else than is strictly needed, then this will be done. If you can go to a specialist rather than a GP or a nurse, then you will do that. In healthcare markets, the doctor decides what treatment a patient should receive. Patients do not know what care they need and are not able to critically assess the doctor's advice. Patients are also insensitive to the cost of treatment because these costs are borne by a third party, such as the medical scheme. Their decisions are not influenced by prices as they would be in a normal market. In perfect conditions, therefore, the doctor would only prescribe treatment that is medically necessary. If this relationship breaks down and the doctor recommends or encourages a patient to consume more care than is required for their medical problem, this is called the supplier-induced demand. This happens, for example, if the doctor orders more tests than are absolutely necessary, conducts cesarean section when it is not necessary to do so, admits patient to hospital when their condition can be treated out of patient, or admits patient into an ICU when a general ward admission would be appropriate. In short, utilization rates are worrying. The absolute age-adjusted hospital admission rates in South Africa were higher than all but 2 of the 17 OECD countries compared against. The health market inquiry also evaluated utilization for discretionary procedures. For 6 of the 7 procedures that we studied, the South African utilization rates were higher than average. 4 of these, namely cataract surgery, arthroplasty, tonsillectomy, and cesarean sections, South African private sector utilization was higher than all other countries in the sample. South Africa's age-adjusted ICU admission rates in the private sector were also higher than all 8 countries for which we had data. This is a startling finding, we believe. For the same length of stay, patient age, chronic and illness profile, and procedures provided, an admission that includes an ICU stay would cost approximately 38,000 more than one that doesn't involve an ICU. If the South African private ICU admission rate per head of population were reduced to half of its current level, that is, to between the rates that one finds in countries such as Belgium and the United States, and half of the costs associated with these avoided admissions were reinvested in better awards care, we believe that we would still save approximately 2.7 billion annually, which amounts to just over 2% of private healthcare spending overall for the period that we studied. The health market inquiry found that for all hospital admissions, that is, including the prescribed minimum benefit and those that are non-PMP admissions, in 9 out of 11 specialties examined, there was a significant positive correlation between the risk of admission and having more doctors or hospital in that particular geography. Similarly, there was a significant positive correlation between the risk of admission to ICU and the number of ICU beds in a geography. This observation, when combined with the fact that the ICU admission rates are high by international standards, suggests that utilization is at least partly driven by supply of doctors and facilities rather than patient need. The utilization analysis also found evidence of adverse selection. Members who had recently joined a medical scheme were more likely to be admitted to hospital, other factors, of course, being equal, than members who had been members of the scheme for more than 2 years. Now, let me highlight some of the findings that we made in relation to the specific service providers, starting with the funders market, which, of course, as I've indicated, includes medical scheme administrators and brokers. Overall, our observation on the funders market is that there are few incentives to ensure that scheme employees, trustees, and principal officers act in the best interest of consumers and hold administrators to account. In the current model, administrators have far more analytical capacity and the know-how than the schemes, and administrators seem to make decisions on behalf of schemes, even on key issues of strategy. The so-called separation between not-for-profit schemes and for-profit administrators often seems artificial, particularly in the case of large open schemes. As a result, administrators face insufficient pressures from schemes to deliver better value for money or to lower non-healthcare related costs. Competition in the funders market is neither as vigorous nor as effective as it could or should be. In both the administration and open scheme markets, one large player, for example, Discovery Health in administration and Discovery Health Medical Scheme in open schemes, leads the market, especially in terms of growth, innovation, profitability. Other players largely follow its lead. The most important finding for our profitability analysis in the funders market is that competition is simply not as vigorous as it should be, and in fact appears to be almost non-existent. The analysis conducted over a 10-year period stretching from 2016 through 2015 shows that one player, for example, Discovery, recorded sustained high profit over the entire period, much higher than its competitors. Under normal competitive markets, under normal competitive market conditions, such a situation would see incumbents or new entrants into the market disciplining, as it were, highly profitable firms. Making a profit as a first entrant, of course, is what is often seen. Sustaining over years and maintaining difference between the most profitable firm and its competitors is what leads us to conclude that the market is not competitive. We also have some concern about the nature of competition among funders where it is occurring. This is limited to competition between schemes on factors aimed at improving affordability and value for money of medical scheme cover. There is a limited competition between these schemes on factors that are aimed at improving affordability and value for money of medical scheme cover. There is also limited evidence of schemes entering into effective alternative reinvestment models to contain expenditure and encourage value-based contracting. Instead, schemes compete primarily on risk factors such as attracting a younger and healthier population relative to peers. In addition, we have found that there are failures in regulation, governance, and adverse incentive associated with current market structure that contribute to the lack of competition on value and prices and that limit innovation. The practitioners' markets. Healthcare practitioners are central decision makers in the use of healthcare services. Consumers are usually unable to judge what care they need and rely primarily on the guidance of their healthcare provider in this regard. Practitioners, therefore, have the ability to drive nearly all healthcare expenditure by virtue of the agency role that they play. To understand how practitioners affect competition, we evaluated the market power of practitioners, the incentive they face that may drive expenditure and utilization, including the effect of fee-for-service reimbursement on driving expenditure, and the regulations that limit innovation, team-based care, and competition. There is obviously very little competition between practitioners across specialties. The primary competition analysis focused on competition within areas of specialization and the vertical relationship between practitioners and facilities. We found that the practitioner market is still quite atomistic, with most medical practitioners working as individuals in their own private practice and charging on a fee-for-service basis. Practitioners are not forming multidisciplinary group practices or developing team-based models of care that can deliver greater value at a lower cost. This, of course, is partly due to the regulatory constraints which are addressed in our recommendations. Practitioners are also not compelled to report on outcomes and the quality of services provided. This makes it difficult to track their performance and benchmark outcomes against others or against best practice, and to engage in value-based contracts that may be more beneficial to patients. We are also concerned that practitioner associations, which often represent competing practitioners, have a chilling effect on competition and in some cases engage in horizontally restrictive practices. Now, turning to the hospital markets. The private hospital market is highly concentrated. At national level, the three largest hospital groups have a market share of approximately 90% based on hospital admissions and more than 83% based on registered beds. In the majority of local markets, concentration levels are alarmingly high according to several recognized metrics commonly used to screen for concentration in markets. One of the challenges of this, from a competition perspective, is that it affords, of course, the big three hospital groups what one may call, for want of a better word, a must-have status in bargaining for contracts with funders, which reduces the funders' countervailing power. We make recommendations as to how to address this high concentration. In terms of the nature of the competition in the hospital market, we note that most of the hospitals in South Africa are large acute-based facilities, and although there has been increasing entry by day hospital in recent years, the hospital market seems to lack dynamism, with few entrants following similar models to the three large hospitals, that is Netcare, Mediclinic, and Life Healthcare. The relationship between facilities and practitioners is crucial to understanding competitive dynamics in the facilities market. Hospitals do not compete directly for patients, but rather compete for practitioners who refer patients to hospital. The Health Market Inquiry identified various incentives and arrangements between facilities and practitioners designed to attract practitioners to their hospitals and to maintain or increase admission rates. And I want to turn to the recommendations that we are making. And again, I do not propose to go through every recommendation that we have made, but I intend simply to focus on the main recommendation and those that relate to the two contested issues. We have not, of course, previously engaged with the stakeholders on our preliminary recommendation, and we therefore consider it appropriate, at least at this stage, to indicate the kind of criteria that we use in developing the preliminary recommendation, and also to provide a framework for determining an appropriate remedy. Now, in considering an appropriate remedy, we are required to measure or to recommend measures that are aimed at addressing harm to competition. An appropriate remedy is one that is effective in achieving its aim. It is a remedy that is practical and that is capable of effective implementation, monitoring, and compliance. In addition, an appropriate remedy must be proportionate to the harm that's being addressed. Proportionality requires that the remedy should be the least burdensome remedy and must not be disproportionate to the harm that it seeks to remedy. The primary recommendations, the preliminary recommendation, I should say, which we have made, must be viewed as a package. We have identified multiple and interrelated failures that have an adverse effect on competition. The interventions we have proposed are similarly closely interrelated, and market failures may persist if a partial approach to implementation of the recommendation is adopted. In considering these recommendations, we would therefore urge stakeholders to consider the links between recommendations as well as the sequence of implementation of this recommendation as we specify in the preliminary recommendation. Now, turning to the recommendation that we're making in relation to the funders market. The preliminary recommendation pertaining to funders market are aimed at improving transparency, ensuring that schemes act more concertedly in the interests of scheme members, in holding administrators to account, and ensuring that schemes act to reduce supplier-induced demand and curtail excessive costs. Preliminary recommendation include the following. Firstly, medical schemes option must be simplified by introducing a base benefit option that covers catastrophic expenditure as well as out-of-hospital preventative and primary care. The base benefit option should be standardized across schemes so that it is easy to compare and will be obligatory. All medical scheme members must purchase the base benefit option. Second, we recommend that a risk adjustment mechanism be implemented with respect to base benefit package. This will remove schemes' incentive to compete on demographic risk factors such as age, and will instead encourage schemes to compete on factors such as value for money and innovative models of care. Thirdly, various recommendations have been made to improve the governance of schemes and to ensure that schemes act in the interest of members in holding administrators to account. These include ensuring that the remuneration of trustees and principal officers' remuneration is explicitly linked to objective performance-based criteria, that minimum education and training standards be put in place for trustees and principal officers, and that schemes actively encourage member participation in annual general meetings. This could take place, for example, by increasing the quorum for properly constituted annual general meetings and making use of mobile and other platforms to facilitate remote participation by members. We also recommend that the period of election of scheme trustees be extended to give as many members and as possible an opportunity to vote. To this end, electronic voting must be considered, and voting must be completed and audited prior to the annual general meeting. And at the annual general meeting, the final result must be confirmed by auditors and officially recorded. Coming to the providers, that is on the supply side recommendation. Our primary concern in the hospital market is the high level of national and local concentration in hospital markets. The National Health Act of 2003 makes provision for certificates of need to replace hospital licenses. Some of the factors that must be considered before issuing a certificate of need include the following. Firstly, the need to ensure consistency of healthcare services development in terms of national, provincial, and municipal planning. Secondly, the need to promote an equitable distribution and rationalization of health services and healthcare resources, and the need to correct inequities based on racial, gender, economic, and geographical factors. If this process were implemented and these principles are properly applied, the new licensing framework could promote innovative entry and competition to the benefit of consumers. These provisions of the National Health Act, regrettably, are yet to be implemented. We urge the Department of Health to implement this without delay. The inquiry has also considered a number of alternatives on how you can deconcentrate market. Some of these options that have been considered include divestiture and imposing a moratorium on issuing licenses, in particular in those areas where there is already a high concentration. However, these recommendations raise a number of issues, in particular issues of proportionality, their effectiveness, and whether or not they constitute the least intrusive means of achieving the objective of greater competition. And it is on that basis that we invite the stakeholders to make submission in this regard. But more broadly, the inquiry has found that the current regulatory measures on the supply side of the healthcare market are limited and fragmented compared with other countries where there is often a single dedicated supply side regulators. In South Africa, the supply side has generally been left to operate within a fragmented, poorly enforced regulatory system with weak oversight. The existing regulatory system does not go far enough in terms of achieving optimal healthcare outcomes and appropriate access to quality healthcare services. And for this reason, we recommend comprehensive recommendation for additional supply side regulation, at least in 4 areas: healthcare capacity planning, conducting economic value assessment, implementation of appropriate payment mechanism, and outcome measurement registration and reporting. For effective and efficient regulatory oversight of the supply side of the healthcare market, we recommend the establishment of a dedicated healthcare regulatory authority, which we have named the Supply Side Regulator of Healthcare Services. I do not propose to focus on any of these 4 areas, but there is one which is frequently raised with the inquiry, and that is health services pricing. And one of the most frequent complaints made to us is that there is currently a tariff vacuum in the private healthcare sector that makes it very difficult for schemes and members to estimate and compare the cost of care among providers. We have 2 proposals to remedy tariff vacuum. Firstly, a regulatory solution where the supply side regulator will set tariffs after extensive consultation with stakeholders in a public forum. Secondly, a multilateral price setting mechanism where stakeholders conduct tariff negotiations and reach agreement under a negotiation framework determined by the supply side regulator. In both cases, failure to reach agreement and/or fundamental disagreements with the outcomes of the process will be resolved through a process of compulsory arbitration mechanism. And regardless of the eventual form of price setting mechanism, we recommend that the tariffs for prescribed minimum benefit should be binding, and the tariffs for non-PMB conditions will have the status of reference tariffs. Bilateral negotiations between funders and providers, not just corporate providers like hospitals and pathologists, are wholly supported by the health market inquiry. We see bilateral negotiations as essential if wider adoption of meaningful risk transfer through performance-based contract is to be attained. The inquiry also proposes that a broad group of stakeholders be involved in price setting forum. Representatives of providers, funders, government, and civil society should also participate in the process. Now, coming to the practitioners. The health market inquiry recommends that coding system across the sector be standardized to facilitate meaningful sharing of information. The codes should be managed by a public entity. We recommend that the supply side regulator for health be responsible for the adoption and standardization of alphanumeric codes, descriptors, and relative value units. Applications for new codes or modification of existing ones must be submitted to the regulator for review and final determination. We have also found that provider networks, such as designated service provider networks or preferred provider arrangements, are generally positive for consumers, as they reduce cost and do not unreasonably restrict choice. There are, however, concerns about the potential exclusionary effect of these networks. The Health Market Inquiry thus recommends that there be greater transparency in the selection of designated providers to be on the scheme network. In particular, we recommend that designated service provider partners should be appointed after an open tender process, with the results of the tender being lodged with the supply-side regulator for health. Designated service provider contracts should be no longer than 2 years. Finally, the Health Market Inquiry has found that some of the ethical rules of the HPC SA have an adverse effect on competition, and we recommend that these rules should be reviewed. The rules, as currently interpreted, make it difficult for multidisciplinary practices and partnerships to be set up and for effective alternative reimbursement models to be developed. The rules should be reviewed with the aim of creating an environment that allows practitioners to adopt new and innovative models that may lead to better outcomes for patients. Now, that brings me to the end of the preliminary conclusion. Now, let me say something about what we expect of the stakeholders and the public in general, for that matter. What these provisional findings do, they represent our observation on evidence that we have collected and reviewed thus far. And with a few exceptions, they are a product of extensive engagement with stakeholders on some of the profoundly difficult issues of economic models and competitive assessment which underlie our findings. And make no mistake, there are still fundamental differences between the Health Market Inquiry and stakeholders on some of the issues covered in the report. These include the reliability of data that we have used, the methodologies used, our application of those methodologies, as well as the primary conclusion derived from our analysis. These differences are reflected in our report. But what the provisional report does, it provides stakeholders with the opportunity to see how their comments have been dealt with in the provisional report. And if their concerns still persist, these will be dealt with during the comment period of the provisional report, which allows further opportunity for engagement on these important issues. And the provisional report, therefore, provides a basis for further engagement with stakeholders on these issues. The report, I understand, will be available this afternoon on our website. Stakeholders have until Friday, the 7th of September this year, to provide comments on provisional findings and proposed recommendations. We would urge stakeholders to engage constructively with the provisional report and provide detailed submissions in respect of our provisional findings and proposed recommendations. All submission, as always has been the case, must be substantiated and, where possible, must be accompanied by evidence to back up the submission. We will consider all comments and, if necessary, revise the report with a view to publishing our final report on the 30th of November this year. And let me conclude by thanking the stakeholders for their participation in the inquiry over the last couple of years. We trust that the spirit of cooperation which has permeated the inquiry thus far will continue over the next few months as we work together in the interest of more competitive, innovative, accessible private healthcare sector. And I'd like to thank my colleagues on the panel and the technical team for working tirelessly to ensure that this report is published today. And above all, and perhaps on a personal note, I'd like to thank them for educating me on some of the intricacies of competition economics and health economics. And I need to record the panel's appreciation of the support that we have received from the Commission from time to time. And I'm sure I speak on behalf of all my colleagues on the panel when I say we thank the Commission for entrusting this important task on our shoulders. Thank you indeed for your attention. Thank you.
Thank you very much to Justice Mwabo. Good day, ladies and gentlemen. We're now going to take questions and clarifications. We have a couple of roving mics, and I'll try and make sure that I balance in terms of those who have questions. So we'll move from this side towards that. We'll take probably 5 at first. If there are more, then we'll increase it in terms of the demands or the number of hands that have been raised. So if I move and I pen quickly, I think the first question is there. If the mic can move to the gentleman. For now, I see only one hand. There's a second hand in front. I'm sorry, there's light, okay. The second hand in front, there's a lady here, which is number 4, and number 5 will be right at the back. So it's number 5, number 4, number 3, number 1 is there, and I'm missing number 2. Okay, if you can go to the gentleman right at the back, please introduce yourself, your name and your organization, if possible. Thank you very much.
My name is Khosi Litlape. I am from the Health Professions Council of South Africa, which is one of the cited parties in the report, and I'm the president of the Health Professions Council. I have a few questions. The first one is, and thank you, Chief Justice, for the report and for the team. The first question is about schemes competing on models of care. And just to try and have an understanding, because in terms of our mandate, the responsibility for care is to register practitioners who have been trained, who are providing services licensed by the different statutory bodies. And I just want to understand where schemes are registered, where they have that training about models of care, and how that is going to work. The second question is relating to tariffs. Prior to '94, before the baton was handed over to the new government, we had an organization called the Representative Association of Medical Schemes, which was a statutory body, which did exactly what is being suggested. Would it be simplistic to say what is being suggested is to bring back that Representative Association of Medical Schemes as a statutory body that would then negotiate with the different stakeholders. On the issue of practitioners, we're talking about a standardized coding system. And in the new government from the early 90s, there was a group called FISC that was tasked with doing that responsibility. And I guess in typical South African style, it's an unfinished job that probably needs finishing now. And I just have a question on provider networks, which are described as positive for consumers, which may be exclusionary in nature. Would it not be better for funders to say, these are the conditions to be met by practitioners? And any practitioner that's prepared to meet those conditions is admitted into that network, rather than creating clubs. Because for me, that would then be an open network where everybody knows the rules, where the patients have their choice, and the practitioners can compete among themselves. When people club according to historical lines, others that are minorities get excluded from these arrangements. So I just have a cautionary on those issues. Now, our ethical rules have been highlighted as having an adverse effect on competition, multidisciplinary practices, and alternative reimbursement models. Now, our task is to protect the public and guide the profession. And as professionals, and I'm an ophthalmologist in private practice, we take responsibility for our individual action. And we protect the public by holding the individual practitioner responsible for their professional decisions. When they now go into groups, we would need a debate in the profession. Are we now going into the mode of joint and several liability? So if you're treated by a team and something goes wrong, that whole team collectively takes responsibility, even if it's across statutory bodies. How does the patient know who really messed up when you are being treated by a team of 7 different healthcare professionals that might be reporting to different statutory bodies in terms of accounting for their professional actions? Our rules are based on contracts with humanity, and they are not driven by payment mechanism. They are not dependent on whether a patient pays or a patient doesn't pay. They are about our contract with humanity. And we would be cautious when monetary considerations begin to be what defines our ethical values as professionals. And we will engage, but we'll ensure that we are not treated as a commodity, that access to professional services cannot be a market issue or a commodity issue, given the oath that we take. And we are ready and prepared to engage. And we will never abandon our oath to put our patients first. And those that register with the Medical and Dental Board must understand that that responsibility is what makes us a profession. And once you go into clubs where accountability to patients might be clouded, we should be very careful to be taken on that monetary pathway. So I have those issues. And lastly, a comment to say it's probably time to tell the truth that the pricing vacuum was created by the Competitions Commission. And they need to account for the pain and the mess they have caused to South Africa. And secondly and lastly, those of us that come from being discriminated should wake up and understand that prior to 94, a system that may have been troubled but was working was poisoned by being crippled by the destatutorization of REMS and basically turning the medical schemes environment of solidarity into a profit environment. And it is sad when a piece of legislation from Parliament was meant to be not for profit, we hear about the year-on-year profitability of participants in the Medical Schemes Act. And that evil chalice, that poison chalice that was given to this new government by the previous government needs to be corrected and reversed. Let's wake up, build a South Africa for South Africa. Health cannot work. Haves are separated from the have-not. That would be a crime against humanity. That would be unethical. And whatever we do going forward has to be done. All South Africans cannot create a separate pot, perhaps. And I, at a personal level, and as a head of a statutory body that has to work with government, will do all we can to mobilize people to engage the proposals coming.
Thank you very much, sir. I hope the questions have been noted by the panel. I'm not sure whether do we go to next questions or do you want to address this one first?
Okay. Well, I'll tell you what, some of us have limited memories. We would have to have an external drive to be able to store 20 questions at a time. So may I suggest we do this? Given the number of issues that have been raised here, shall we first deal with these questions? And I think it is appropriate, and I think my colleagues here will be very cross with me if they do not have a say in matters of this nature. Here is what I propose we deal with these matters. There are matters pertaining to funders, there are matters pertaining to practitioners, and those pertaining to hospital, and matters pertaining to processes. We will divide answers along those lines. Dr. Bengu will take care of the hospital, of the hospital groups and tariffs. Dr. Nkonki will look after the funders. I will look after the process and make sure that it remains fair. And Professor Fon will look after the practitioners. But of course, we are not going to we're not limited to these categories. Professor Fon will also deal with supply-induced demand. Okay? All right. Starting with the 5 questions that have been asked. Dr. Bengu will take the questions. Yes, Nolos.
Thanks, Judge. Good morning, everybody.
I should also add that for purposes of fairness, the commissioner is here. He is here to answer for himself about some of the comments that were directed at the Competition Commission. I think if he's minded to react, he will do so. Thank you so much indeed. Yes.
Thank you, Dr. Letlhapane. I will deal with the question on tariffs. Linked to that will be the provider networks. I think the proposal, the recommendation that we're making regarding pricing needs a bit of unpacking to be understood. There are 3 levels to it that are worth remembering. One, it's how we arrive at fee-for-service tariffs for PMBs, and judges already referred to the fact that those will be kept without any co-payments allowed. And the other component on a reference pricing basis would be for all other non-PMBs. Now, what this means is that immediately you do away with the tariff vacuum, because that process alone will make sure that as much as we don't like fee for service, there will be a price for every service procedure rendered. The next level would be the introduction of an independent arbitrator as a means of breaking the deadlock where there is not agreement between parties. What's relevant here is that to curb the chance that this could be abused, we insist that parties will not have an opportunity to introduce new arguments when the matter goes to arbitrator. In that way, we hope that we will get your best arguments up front, knowing that you will not have a chance to manipulate or change the facts to suit what you want. So we hope that will work. And the third level is basically the retention of bilateral negotiations, which right now are certainly favored by your corporate type providers like hospitals, like pathologists. We support this and we would like to see more of it because that's where the opportunity to move beyond fee-for-service comes in, because these contracts will then basically be will take into account volumes, will take into account price, and more importantly, quality. Now, I just want to go back to the first part. I was just laying out the three levels, just the first part, purely because there are two parts to that. And when Dr. Litlape asked that, are we bringing back RAMS, remember that there are two proposals on the table. What we refer to as the multilateral negotiation forum is probably what's close to what Dr. Litlape is talking about. And here, there is a big difference in our opinion, because this is not just RAMS sitting by themselves and providers, but this is now happening under the guidance in regards to terms of reference, guidelines, and active management by the pricing unit of the supply side regulator. So that's important. It's not stakeholders just doing it by themselves. Stakeholders will negotiate, arrive at what they deem to be prices that they can live with, however you want to define it, but will still be validated by the regulator. And if they do not like that, then that process arbitrator kicks in. So that's the one model. The second model is the one we refer to as the regulatory option, and it's certainly a departure from what Dr. Litlape refers to the old RAMS situation. And here, remember, we motivate for a regulator that's independent, that's staffed by professional, experienced, highly technical people, and independent. It's independent both from government and from industry. But it would still sit with all stakeholders, hear arguments, listen to presentations, and through its own research will determine what the tariffs will be. So the regulator now determines after listening to everybody. And if stakeholders don't like that, they will then take it to the arbitrator. Now, there are three issues here because, of course, whenever the issue of regulator comes in, the worry is whether there will be fair desks or what we said that we talk about. Two, we must also remember that the non-PMPs are reference prices, but also there is the opportunity to still, if you do not like the regulator to tell you what to do, there's still the opportunity to then maybe deal more on a bilateral negotiation basis. We hope this will, if this is the method that is sustained after your comments, what it would do, it would facilitate more more towards bilateral negotiations, so it's not just price only. Now, I hope the two models are clear, but I can understand it's not, but you will be able to read what we mean Regarding provider networks, which by the way are related to this, we received a lot of recommendations that we go through the process of fixing prices, and we have not supported that. We believe that provider networks can actually deliver more. We're saying this because we have seen submissions, some on a confidential basis, where service providers, where hospital groups, a large hospital group says, we offered Scheme X a 25% discount on pricing and we still didn't make the DSP. There are many such examples. And if you look at it, there is no other tool that we've come across where just on proposals we're talking about 25% discount. It is true that we are aware that the whole issue of access might be impacted, but that's where the guidelines come in. You will see in the report we've proposed guidelines. Among some of them, obviously, the question is the DSP is too far. You can't penalize in an emergency. It can't work. And the other question now regarding that it could be exclusionary. On the question of if all practitioners are willing to meet the terms of the network, they should be part of it. We accept that only to the extent that if it's fee-for-service agreement, we think that there is a case to be made for that. But where we are looking at alternative reimbursement models, which is basically where we see quality being addressed, we see volumes coming into the debate, we see pricing, we certainly fall on the side that for that to work, first of all, you need to have contracts up front. And that alone determines the need that it should be sort of exclusive in a way, and that's not a bad thing. We will, when we talk about licensing, if we get there, you will see how we try to address one weakness that schemes say their databases of members are not always reliable as to physical placement, and that affects the issue as well of how the DSPs and networks can. So we do believe, Dr. Klape, that there is room for this, but the overriding principle is that these networks must engender cooperation among practitioners and competition among providers of product. I will stand there, but there certainly are protections for consumers and in the form of guidelines which we have included.
Thank you, Dr. Alitape, for your question. I will focus on the first question you raised around different models of care or in relation to medical schemes. And I wish to clarify that our remedies seek to promote an environment where schemes promote alternative models of care as well as alternative reimbursement models. And so what we have observed through the duration of the inquiry is that medical schemes tend to compete more on the downstream market, meaning, in other words, they tend to compete more for members. And there is less active engagement in terms of how they seek to shift their prevalent reimbursement methods, for instance, such as fee-for-service, in particular around providers. And so we've also observed and we've come across a few innovative models that seek to promote multidisciplinary team-based care, where there has been low uptake of those by medical schemes. So our remedy is to promote an environment where medical schemes move more towards uptaking and seeking models of care that include multidisciplinary teams, moving away from a fee-for-service reimbursement models, and where they negotiate contracts that seeks to shift the risk on utilization on members and more onto providers as well.
I'll just make one point. The only way to purchase something intelligently is to have some measure of quality. And so one of the big recommendations that we make is measures of quality, and particularly health outcomes. And so a lot of provider networks, a lot of choices, any of these things would only make sense if you have a measure of quality. What are you purchasing? So it's all very well going to the doctor you like, but the doctor you like might not be the doctor that's getting the best health outcomes. And so whether you're in a provider network or whether you're in a particular model of care, doesn't really, what's really at heart and what's totally absent in this environment is systematic measurement of quality. And this is a very big recommendation that we're making, and I think that it answers many of the questions that Dr. Leklapi asked. For me, once we start putting quality and health outcomes into the environment, a lot of the questions become clear. Whether you're seen by one doctor or whether you're seen by a team, that doesn't matter. It's whether you get better that matters. And it seems to me that these are the measures that we want to be seeing introduced into the market.
You know, may I just make one comment, and that is the issues that have been raised by Dr. de Klapp raises the question of the interaction between competition, law and policy, and the Constitution. And as I have emphasized at the beginning of the presentation, we are considering these issues purely from a competition standpoint. We are not considering these issues from a broader constitutional perspective, which is much more comprehensive, which is much more broad than the sort of narrow approach on whether or not there are factors that undermine competition in the private healthcare markets. That's the focus of this. It is a totally different inquiry to consider broadly whether in this country there is sufficient legislation that gives effect to the constitutional right healthcare services, which is enshrined in the Constitution. There are a whole host of issues that we may have to put in that regard, which would include price, for example, quality of service, but from a constitutional standpoint and the obligation that the Constitution imposes on the state to give effect to this, including, amongst other things, to make sure that when health services are provided by the private healthcare sector, the state remains obliged to regulate the manner in which those services are provided, including the affordability of those services. But that's what, which is different from saying, how is competition working among doctors, among funders, among hospitals?
The Commissioner will come and respond to some of the comments directed at the Commission.
Thank you. I was not planning to speak, but I would briefly want to take the opportunity to thank Justice Ngobo and the panel for the report and all the work that's been done. But the question that's been asked also helps to situate the inquiry. As you would appreciate, whenever you have an intersection between a public function, which is the provision of healthcare services, just like you would have with education, and you also have the private sector playing a role in this, you always are going to have complexity, because as soon as you introduce the private sector, you are introducing different incentives into the system. We can assume that the Minister of Health doesn't want to make profit, but we can't assume the same of the private sector. And one of the ways in which you can make profits is to distort competition. So the Competition Commission for a long time had been looking at these markets earlier in the 2000s, as you would know. The negotiations between the funders and the providers. This was done through some form of bargaining. All of you know this history. And there were complaints that as soon as you have people getting together to negotiate as a price, in a normal market, that would be price fixing. And so the conclusion of this was some settlements, for example, with the Board of Healthcare Funders in 2005, that stopped them from collective negotiations. Now, I can assure everybody that once the consequences of that were felt, we got various concerns from various parties. One of those parties was the Minister of Health. When he came in 2009, himself said, the system is not working, and in fact said, will you reverse the ruling? We said to the minister, it doesn't work that way. You can't reverse a ruling. Once the tribunal has made a ruling, that is the ruling. But anyway, to cut the long story short, this culminated into a recognition that perhaps there is a market failure. And as a regulator with an open mind, we said, well, let's get an independent panel that is going to look at the possibility of this market failure, given the background of the research that we had done, which the judge had referred to, that showed that the costs and prices were rising. And so I'm very delighted that we are where we are. We look at this with an open mind. The idea is to fix this for patients. So it doesn't matter who was to blame. This country is full of blames. It doesn't matter at this stage. I think that we are looking at this with an open mind, with the aim of fixing it. So I will not get into the merits of what is being proposed. All I would ask is that I think we should engage with the process, and perhaps this is the beginning of that engagement. Because in the end, we must find a solution that will promote access to healthcare in South Africa as the Constitution requires. Thank you.
Thank you to Commissioner Thembinkosi Bonakele. Before I go to the next set of questions, I omitted to mention that the purpose of question and answers is to assist those who are going to write stories and also those who are going to make submissions in terms of the preliminary report. And some of the very many issues that you may feel strongly about, they should be incorporated in your submission as the process is being taken forward. So I move to the second set of questions, hoping that we will keep it to maximum 2. I know that we have a precedent already, but if you have more, sure, but let's try and make sure that we ask those questions to make sure that they assist us, as I said earlier, in terms of submissions and writing stories. For members of the media, once we are done with the stakeholders, many of whom are here, we are then going to have another session if you believe that there are questions that you could not answer or we ran out of time, so that we can then focus on those questions in order to assist you in the process of improving the quality of your writing. So I go to number 2. I hope that we have kept the numbers that we had identified earlier. We go to number 2, and then number 2, number 3, up to 5. And then the panel will address those questions and clarifications, and then we'll see after that if we still have more of those. Thank you.
Thank you. Brian Ruff from PPO. So, first of all, let me congratulate the inquiry on a job well done, and thank you. In particular, that you've identified over-servicing as a major issue, and that the problems in the industry are not just price. You made for the first time significant comment on regional concentration in general, but regional concentration, and I think it's very important understanding that actually healthcare is delivered locally to local populations. Obviously, I haven't seen the 800-page report. Can you share with us whether you've made any recommendations in regards to concentration or at a local level?
All right, we'll go to number 3. Is that number 3? Yes, please. Thank you.
Thank you very much for the opportunity. I think based on your articulate comments about the purpose of the questions, I'm going to withdraw. Thank you.
Thank you. Thank you very much. We go to number 4. Is that number 4?
Hi, it's Catherine Child from the Sunday Times and Times Live. 2 questions. Is it fair to say that government has pointed out quite broadly here, while you're looking at the private sector, over and over again you point out that they haven't regulated properly, or the HSPCA stops teamwork? And the other is then, if governments sort of come up short in terms of regulation or giving too many hospital licenses, who then will measure quality? So you want quality measured, are hospitals actually helping patients? Is that going to be an independent body? Will it be the hospitals themselves? That's first. So if you could just answer that.
Thank you. We move to number 4. I think number 4 was in that corner, right?
Thank you. My name is Selaido Mameja. I'm from the South African Medical Association. I just want to find out if, firstly, I think that the inquiry did a very good job. Thank you for painting the picture on the tariff setting and making an effort to outline the fair process. I think it was our worry that the process wouldn't be fair, and I think the mechanism that you've put in place is going to assist quite a lot. In doing the analysis, I want to find out if you've looked at the benefit option design on whether it does increase supplier-induced demand. The reason I'm asking this is because we have different option plans. If you belong to a lower option plan, the battle every day is we need you to get a basic care that costs 20 or 25 rand. We need you to have an investigation that is clinically justifiable, and you can't get it. Yet, when you go higher up in the option plan, some of which are loss-making, you can get what you want. So in the interest of equity, has Competition Commissioner looked at this? And in terms of the members of the society, the amount of money that they put in, the issue of late joiner penalties, this is likely to affect people who were economically disadvantaged prior to 1994 because access to medical schemes was not as open as it should be. Has the Competition Commissioner looked at that? And differential pricing, you indicated that there will be tariff setting, however, there will be a standardized pricing for PMBs versus for non-PMBs. Let me give you an example. Osteoarthritis is not a prescribed minimum benefit, but hip fracture is a prescribed minimum benefit. Both of them, when you reach end stage osteoarthritis, we do need to give you a hip replacement. If you fracture your hip, we need to give you a hip replacement. Are we going to have two prices of the hip replacement? What will be the, have you considered the unintended consequences of that? And my last question is, I've read here you've spoken about the profit making in the administrators. However, we do have managed healthcare organizations. And has anybody looked at the value that they add? Because they are a significant cost driver together with the administration costs. Thank you so much.
I'm tempted to take one more. I think there was one that side, or the gentleman here. Go ahead, sir. Okay, start the lead. All right, we'll take two.
Hi, my name is Pravisha. I have a bit of flu, so give for my voice. I just wanted to find out in the recommendations regarding the transgressions of the medical scheme, is there anything put in place for the regulator of the schemes to probably like penalties as such should the medical schemes not adhere to the Medical Schemes Act? Because I've been a complainant to the Council for Medical Schemes for the past 2 years, and unfortunately I've never got a response back. So in terms of time frames and in terms of non-adherence to the Medical Schemes Act, which is just a simple administrative query, but nevertheless almost sort of making me exit the retail pharmacy industry by their non-compliance to the Act, and the regulator not doing anything for the past 2 years. Is there anything of that nature in the recommendations that the schemes and the principal officers and the regulator especially should be held accountable? Thank you.
Thank you, ma'am.
Thank you very much. My name is Casey Makubele. I am the CEO of the South African Dental Association. Again, thank you to the Commission for having done what they've done. They've raised quite a lot of issues that many of us in the industry are very much aware of. I've got two questions. When I look at some of the recommendations, we seem to be moving to centralization in terms of regulation to make sure that we have some sort of standardization. The one question that I want to raise is, are the recommendations when we go into centralization to make sure that that system is efficient? Because if you look at it, particularly in terms of the regulation side of things, many of the regulatory bodies that have come out and be standalones is purely because they feel that the current system of one regulator has not been efficient. That's the first question that I want to ask. The second question, we spoke about, when we talk about the medical aid scheme and how money is being utilized to deal with the diseases in the country or the illness in the country. And we do all agree that some of the illnesses that are supposed to be paid for by medical schemes are not paid for. In actual fact, I would go as far as say, my feeling is that when you look at the commercialization of medical aid schemes, they tend to provide more money for illnesses that are not actually the majority in the country. So the question that I want to ask is there a recommendation, or maybe the Department of Health is going to look at this in terms of re-looking at current research with regards to the burden of disease so that we may be able to allocate the funding appropriately. I thank you.
Thank you very much. Before I hand over to the panel to address the questions, we'll do the second round just after these ones have been addressed. I just want to say that all the documents have been uploaded on our website and they have been emailed to all members of the media. So for ease of reference, you can also look at those documents. Thank you. Over to the panel.
I'll take some of the questions. First of all, in general, one of the recommendations is a review of the PMBs. So a lot of the questions have been around that, and there is absolutely a recommendation on review of the PMBs. And also in relation to managed care organizations, a lot of our comments have focused on administrators, but in fact they're included in the funder market. And some of them are in fact directed at equally at managed care organizations. I wanted to talk to the issue of quality. Who's going to do that? Quality is an interesting factor, and it's only meaningful if you use meaningful indicators. And actually our idea is that the participants themselves in the market get together and come up with these indicators, clearly with some expert advice and with some external players, but it seems to us that they need to start off themselves. Now, you'll remember during the hearings, the hospitals have told us, oh, they're all ready to publish, they just haven't done it. And also, I stand under correction, Commissioner, but as far as I know, sharing information on quality metrics is not against the Competition Act. And the fact that they've used this as an excuse as to why they haven't done it has been entertaining, and so we're looking forward to them doing that. The point is to have uniform metrics measured in exactly the same way so that they are comparable. So we look forward to them doing that. And we're also very keen on providers similarly. So you will see in the detailed recommendations, which are now available to you, everyone, type in on your phone, they're there for you to see. The formulation of what so far we've called OMRO, which I can't even tell you anymore what the acronym stands for, one of my colleagues will. But the idea that at least for outcomes registries, that the practitioners themselves get together and decide on how they will report on this. And what we're hoping is that they will do it voluntarily and by themselves. And in the first instance, you know, when you try something new, you want to just check it works. So in the first instance, we'd like them to do it among themselves and have a look at themselves. And in many countries in the world, this happens. If you are, for example, replacing a hip, you'll decide, okay, these are the measures that we're going to use, and all the people who replace hips will feed in their information in terms of patient outcome, and very importantly, patients are included in this. Do you feel better? Can you now walk? Are you pain-free compared to before the operation? Because it's not about if the doctor thought it looked lovely or the stitching was good at the end. It's about whether the patient is any better. And then what we found in other countries, or what has been found in other countries, is those doctors who feed in their information and those doctors who look up, how do I compare to my peers, are usually the doctors who are at the top. And what you can do then as a provider is to say, how do I compete with my peers? Am I average? Am I below average? Am I above average? And you could imagine the Orthopedic Association having a meeting where they discuss it. Okay, you guys who are above average, what are you doing? I want to learn from you. So that's the process that we see unfolding. And ultimately, after a period of time, and we're hoping that it will be concluded within 4 years, it will then be available to the public. So that I can look up, as Joe Soap, which doctor or which group of doctors or which facility do I want to use because they have got good metrics. And that's the way we see it working. So it's throwing it back to the people who provide the services. Show us your quality. This is what the private sector is about. Coca-Cola tell us they're better than Pepsi. You can taste Coca-Cola, you can taste Pepsi, see which one you like, that's the one you'll buy. So if the information is out there, this is good quality, that's the one I'm going to go to. If you want to play in the private sector, then you have to play by those private sector rules. So that's how we're envisaging anyway, those are the provisional recommendations. We look forward to your comments. I'm sure we haven't thought of everything, and I'm sure you might have some good ideas about how to make it even better, and that's what we're looking forward to hearing.
I'll take the question raised around benefit options. And thank you for those questions, because one of our key findings is that the consumer in the South African medical schemes market is not able to exercise effective choice when they're choosing benefit package, when they're choosing benefit options. There are so many different benefit options first, and that these benefit options are not comparable. The industry has termed this product differentiation as innovation, and we are of the view that this is not the type of innovation that we would like to see in this market. It allows medical schemes to avoid direct price comparisons, and so if you are sitting with a benefit option from one scheme, one is unable to make meaningful comparisons to a different medical scheme, and thus many people choose on the basis of affordability. And so one of the recommendations that the judge discussed first when it comes to the funders market is that of an obligatory standard package that will be that will first allow for comparisons between the different medical schemes. But in addition to that, the supplementary cover, we have recommended that it also be presented in a uniform way that will allow members of consumers to compare and allow for direct price comparison. The second issue you raised around hospital plans, the current design of the prescribed minimum benefits is very hospice-centric. And what we have proposed is that in the standard core package, that there is a shift towards in-hospital care, because many of the prescribed minimum benefits, some can actually be treated out of hospital. And so, and we view this to be actually in alignment also with the bill that was published by the Department of Health. There seems to be a shift from prescribed minimum benefits to more comprehensive plans, even though that is not clearly specified. So our key pointers around what the standard compulsory benefit package should entail is that it should cover catastrophic expenditure, shift the incentives towards in-hospital care towards out-of-hospital care, as well as cover some primary health care conditions.
Thank you. Just to start the issue of PMB's one line. Yeah, we have not tried to define what PMBs should be. We're just dealing with the concept of what we now call PMBs, however they're defined going forward. To Dr. Mamecha's question regarding two prices of, can you have different prices for the same procedure? Possibly, yes. What we're trying to say here is that the PMB, there must be a maximum, so those must be kept. I suppose in theory that's possible, because if parties do negotiate, the stopgap is that whatever they negotiate, they cannot exceed what's fixed at PMB level by the fee-for-service setting mechanism. Now, on the question of value of managed care, we haven't gone much into it except to propose that the CMS must develop tricks of how this will be measured and possibly published every 2 years. On the question of, I'm sorry, Ms. Childs, I remember you asked about licensing, but I've lost the exact question you wanted to ask about. Well, the issue of licensing came up mainly from the perspective that the hospital licensing process is not well coordinated, and the way it's working, it's actually behind some of the market failures that we see. On a high level, we did host the provincial departments of health dealing with the subject mainly as well. On a high level, for example, most provinces work on the R158, which is a regulation 158, and the license according to that. The Western Cape, I think it's regulation 187. The Free State works on a provincial act. So just there, you've got at least 3 ways in which hospitals deal with, regulators deal with licensing. We've sought to take this further by basically looking at licensing within the regulator. One would be on practitioners. Okay, I think this is a main point to make here on the licensing as well. Remember that in terms of licensing and certification, there is the first step that will happen outside of the regulator. For practitioners, that will be your HPCSA, that will be your nursing council or allied health. But once they have confirmed that you certified, that's when then the regulator comes in. And this is one of the new recommendations we're making, that the practice code numbering system moves from the BHF to the regulator to facilitate that process. It is outsourced to BHF, but it's the authority we understand of CMS based of what we do. So we feel it will sit better with the authority that's responsible for suppliers as opposed to funders. It deals with suppliers. And but also the new issue here is licensing the practitioner as, separately from the premises from which they work. There is a whole detail that we go into, and it has to do with linking the renewal of practice licenses to clearing up the database as to where practices are located. This is essential to deal with ghost practices. It will enable the regulator to basically do random and schedule visits to practitioners, and it will deal with medical claims fraud. So the section on licensing is quite detailed, and you will find there quite a few more things that I haven't referred to. But it certainly is an area for improvement, and a lot of the ideas actually did come from the Department of Health, both national and the provincial. And it starts with settling for a national plan from which everybody works. Then the provinces will be responsible to enforcing and actually monitoring and providing updates in the system on an annual basis.
May I just make one point, and that is, and I should have mentioned this in the course of my presentation, and that is, a couple of weeks ago, I think it was, the minister introduced 2 bills. The one was the National Health Insurance Bill, and the other one contained some amendments to the medical scheme. And these 2 bills address some of the issues that we have been grappling with. However, we have not had occasion to study these bills closely. They came after the report was in its final stages, and we have no doubt we will engage with these bills going forward. The other thing that I wanted to mention is that the National Health Act 2003 is probably the first statute which was enacted by the new government. Its declared purpose is to give effect to the constitutional right of access to healthcare services. It deals with a whole variety of issues, including the licensing of hospitals, quality of healthcare services and the monitoring of quality, and the provision of information pertaining to healthcare services, which include the financing and the prices. But what remains to be done, of course, is to implement these provisions and to make the necessary regulations which are required. At some point, I think it was about a couple of years ago, the provisions pertaining to the certificate of need were implemented, were brought into operation without there being the underlying regulations that were necessary for the implementation of those provisions. The matter went to the Constitutional Court at the request of the President and after some challenges, and then the bringing to operation of those provisions was set aside. So we're back to square one, where what needs to happen is to promulgate the necessary regulations so as to ensure that the licensing regime pertaining to hospitals, as well as those regulations pertaining to the collecting of information pertaining to health and quality, are properly regulated under the new statute. I am aware that there were regulations that were also promulgated by the Department of Health, which were the subject of litigation in the High Court, and these too were struck down because it was said that there had been no proper consultation, if I remember very well. But what's happening, though, is that, and I feel pity for the minister, is that there's always a constant threat of litigation over these matters. But I do think that it's about time that you go ahead with the implementation of this. If you are challenged, so be it.
Thank you. All right, we will take those hands there and then come to the minister. This is the last round of questions and clarifications. If, as I said earlier, members of the media feel that they need more, so it's 1, 2, 3. If we need more, then we'll stay behind when the stakeholders go for lunch. Thank you.
Thank you, Chairperson. I'm Sipo Kabane from the Council for Medical Schemes, whose mandate is to regulate schemes in protection of members. We will still look at the 800-page report, but we welcome the presentation. My question is around this supply-side regulator that is going to be established, whether in the report it's clearly articulated in terms of its relationships with other regulators, and also if there are any interim arrangements in terms of the implementation of these regulatory functions.
Thank you. Can someone bring a mic to the front? Or is the second person there? Oh, all right.
Thank you, Chairperson. I'm also from the Council. I'm the Chairperson. We would like to say, in broad terms, even though we understand that we have to look in depth at the report. First of all, maybe I should point out that we've got those two bills, we've got this report. So the next 3 months, you've just taken our next 3 months off our lives now. So we're going to have to focus on these bills. and we're going to do that. But at CMS, we've started a road show for our next strategic planning session of 5 years. In our road show, we included quite a number of the issues that are raised in the report. I'm saying that without having gone into the report, as you'll understand. But we are encouraged by the areas in which you focused, because they coincide to a very large extent with what we're working on coding, on alternative reinvestments, on fraud, waste and abuse. So we really are encouraged. It looks like we've got a lot to work on in this next, and we really appreciate it. And thank you for major effort. Thanks.
Thank you very much. I also like the commission. I thought I was not going to speak, just to listen, Judge, but because the department decided many times, I thought it was important for me to clarify a few things, but also be clarified. Because as Dr. Mini said, we now have 3 things to deal with in the health system. We've got the Medical Schemes Amendment Act, Amendment Bill. We have got the NHI Bill. We have got these recommendations here. And they somehow, there's a big cross-section between them. As Judge Ngobo, you've already said, when you didn't engage with the bills, but some of the issues on the bill are to resolve your findings. It is true that those bills were written before you saw what is here. But be that as it may, let me start thanking you, because I think at the Department of Health, from this inquiry, we got more than what we were asking for. And I want to give a background for people to understand. The first thing I want, you are actually asking us that we must sit together as stakeholders within government. Yes, you are actually imposing a sitting together on us. Now, the first thing I want to mention is that people must not pretend that stakeholders have always wanted to be regulated. They don't want to be regulated. And they've been resisting. And we're going to live in court if we did not do something, because there was resistance. Now, Dr. Letlape started by saying the mess was brought in by the Competition Commission. So it's important for me to start from. Yes. Why did I go to the Competition Commission? That private healthcare is becoming costlier and uncontrollable. It's been proven today. Some of us picked it a long time ago. And that was back in 2009 when we realized private healthcare is no longer affordable, even to people who are supposed to be rich, who are on medical aid. And of course, as a minister, I have to understand why. My officials told me, no, the reason is the ruling made by the Competition Commission. That was before Mr. Bonakele's term. So I must say, yes. They said that ruling is the one that caused damage, which is what Dr. Letlape is saying when he said the mess. So I then went to the Competition Commission and said, please reverse this ruling. I am told that is causing a mess. It's the one that is making healthcare unaffordable. And remember, the private healthcare unaffordability is affecting the state. It's affecting the state because workers, every time the cost goes high, they come and demand more subsidies. And I'm sure Judge will have noticed that. That's why the subsidies increased by billions. I mean, in 2015, they were 26 billion. Now, 3 years later, they are 31 billion. Yes, the medical schemes rebates were 20 billion 3 years ago. They are 26 billion in 3 years' time. That comes from the state, so I have to do something. So I said, please, Competition Commission, reverse that ruling. And it took me 3 years because the Competition Commission, as I said no, things don't work that way. I then said, but this high cost, how are we going to deal with them? It took me 3 years for the competition commissioner to accept that the costs are high. There was no acceptance from the beginning. Yes, it took 3 years. And after 3 years, I thought now that you understand, he will reverse the ruling. And they said, no, we're not reversing the ruling. We want to test your hypothesis. Is it true that the costs are actually high? Because we can't just agree with you as a minister. We want to accept the hypothesis. And where was it coming from, Judge? In 2005, after making this ruling, the Competition Commission didn't stop there. They said we need a neutral arbiter to set prices. And that neutral arbiter was selected as the Department of Health, which I think was wrong because I'm not neutral. I'm not going to hide it. There's no way a Minister of Health can ever be neutral on price setting. I want affordable price at all times. Any Minister of Health in any part of the world who doesn't want that is not worth his soul or her soul. So I'm not neutral, but unfortunately the ruling was that we're neutral. And the department then in 2005, 6, 7, 8, set up a panel to set prices, which were challenged in court on the basis of technicalities, Judge, as you were saying, that the National Health Commission was not told to go back. But when I looked at it substantively, there was going to be no end. I said the best thing is to call stakeholders, sit around the table, start talking. You know what happened? Stakeholders refused to come. They said, if you are going to talk about regulation including prices, the Competition Commission has banned us from it. Let them write a letter to say now they allow us to do that. Then I went back to the Competition Commission. Can you write a letter to allow them to come to a meeting? No, we're not going to do that. Because things are not done that way. Then I was in limbo, and I knew if we said and insisted on this regulation that is being challenged in court, we're going to live in court. So that's why I went to the Competition Commission, and then they said, okay, let's set up the commission. That's how you came into being, Judge, with the team. You came into being because of that. And I said, I was not asking for that, but I welcome it. And for the past 4 years, I realized I was naive to believe that just reversing the realms coming together will solve the problem. I was naive because today you gave us much more than that. That's why I'm so excited. You revealed even things which the public didn't know. And then in revealing them, you are bringing certain things that will now lead to my questions. This issue of fighting regulation has always been there. There is a report by Judge Judy Qualapen, who was the chairperson of the Human Rights Commission in 2007, who wanted to investigate whether the Constitution is being applied in terms of access to health. He wrote in that report that there's poor regulation, especially on the side of providers. So because now we are living in court, we said, let's wait for the results of what we're doing. And this is where we are today. Do they now accept regulation because the Commission has proved beyond doubt that is needed, that we're still going to live in court? Now, let me ask a few questions then with that background. One, you said there are two proposals, two models. One is model care of, the first one is a regulator who must set tariffs. We have always been proposing that, but we're calling it the Price Setting Commission, which was also being resisted, but you are proposing it today. But you are also proposing a multilateral tariff, which Dr. Letlape thought you are bringing back REMS, which also I wanted to bring back, but now it's being explained that no, it's not exactly like that. Now, the war is going to be who appoints the regulator. Because it's important to clarify that. Who now appoints the regulator? Because we were calling it the Pricing Commission and we thought the state must appoint it. And it must be independent. We encourage that independence on the regulator. Who then appoints it? That's question number one. Question number two is about this issue of certificate of need. Yes, the certificate of need obviously is redistributed, and it's in the National Health Act. Why was it not implemented? There was a threat for a court, if you remember.
Yes, where people were telling us that no, we are bringing back apartheid. Yes, we are bringing back apartheid by going to force them to be. Because we have already done research, it's scaring actually, Judge. If you look at where health facilities are, in Natal, they are at the coast only. Inside, there is nothing. If you come to, yes, in KZN, if you come to Gauteng and Western Cape, etc., they get concentrated in the major towns. In between, there is nothing. Now, we withdrew it, as you said, when the matter was going to Constitutional Court, and asked the President to ask the Constitutional Court to withdraw it, because we wanted to bring it in the new NH Act, so that it becomes a new policy, which people must debate because they were challenging it on the basis of whether the former acts were strong. So I just wanted people to understand this. It can't be left. And the other thing where we agreed with them, in the Act, Judge, it did not have a grandfather clause. It was saying on the day on which it comes into operation, people who don't abide to it will be punished. So doctors were asking us, if I've put up a practice here, and in terms of the certificate of need, it was a wrong place. So it lacked a grandfather clause. And we said maybe in the new act will be the grandfather clause. So it's not something that we've abandoned as is being proposed. It was just a process. And we are happy that that process is coming to an end. Now, the last question. I asked it knowing very well that the judge said they didn't read our regulations. Isn't our Medical Schemes Act of abolishing co-payments and also changing prescribed minimum benefit to basic minimum benefit? This is not coinciding with Dr. Bongi has just explained. Are we not finding each other there? Because I believe that's exactly what you are. Thank you very much.
Thank you, Minister. The last question will come from that side. So there's two questions.
Sorry, hi, thank you so much. My name is Laura Lopez. I'm with the Bexisa Center for Health Journalism. I was wondering if the panel could speak to what, if any, relationships you found between service providers such as ambulances or pathology and hospitals, and how that was influencing.
Can you repeat, please?
Sure.
Sorry.
Just wanted to know what, if anything, the panel found in regards to relationships between hospital groups and pathology services, ambulances that could also be cost drivers.
All right. And the last one at the back.
Good afternoon, Johan Serfontein from the Private Practitioners Forum. I just have two questions around certificates of need. Are these certificates of need going to be localized to hospital groups, or is that going to be extended to all providers? So that's the first question. Second question is, these certificates of need, which criteria are going to be considered when considering whether a certificate of need is issued? Is it going to be based on national health needs, or is it going to be based on positioning of private patients? Because if you look at healthcare, private healthcare, 95% of private healthcare is accessed by people that are on medical schemes, and as a result of that, service providers follow areas where these medical scheme members are located. If you're going to create a situation where it's based on national health needs, it's not going to work because people that can afford to use private services are not located in these areas. You need to focus on people that are actually going to participate in the private healthcare sector when issuing certificates of need. Otherwise, that is going to cause providers to leave the country. So can you create some clarity on that?
Thank you very much. That was the last question. I'll hand over to the panel again.
I'll start, but I'm going to hand most of them over to, I think, Dr. Bengu's going to answer a lot. You know, I think one of the opportunities that sits in front of us at the moment is the opportunity of who's going to purchase care from who. And so in relation to providing care for people who need care, the caregivers should be where the people who are going to be purchasing that care, people who need the care. You need the two to be in the same place. And the market forces would work such that where there are lots of people who need care, that's where providers should be. And it seems to me that the question then is who purchases or pays for that care. And it seems to me that multiple opportunities are open in front of us as a country in relation to the purchasing of that care. Currently, we think that the only people who can purchase care from private providers are people on medical schemes. I think that that is up for discussion. I don't think that that's necessarily true. If the public sector becomes a purchaser, and in my understanding of the National Health Insurance Act, the public sector sees itself as a purchaser across the board. And it seems to me that the big challenge in front of all of us, and I come back to this point of quality, if you can prove that you are providing outstanding quality, why can't you be someone who provides care to whomever is purchasing that care? And also, one of the things that drives the private sector and profitability is volume. So if there is a high volume of people who are going to purchase from you, you're going to be profitable. And it seems to me that the siloed approach of understanding who buys, who can pay, needs to be something that we have to think about as a country. One of the biggest problems in our country is one of inequality. If we do not challenge that issue, we all suffer. And so it seems to me that there needs to be a bit of a bigger imagination about what is possible in the future. And I think that speaks to the notion of the certificate of need. Everyone sees this as closing down options. It could be opening up options. And also, you want to be busy. If you go to work, you don't want to sit behind your desk doing nothing. Some people do, but preferably the world would be better if we didn't feel that way. And so the idea that you might be in a particular area where there are many people who need your services, and someone will pay you for those services. You will be busy, you will have a satisfying work day, you will meet needs, and you'll also meet some of the obligations of the Constitution. And so I think we don't have an answer to the certificate of need. We have not gone into that level of detail. It's not our job. But it seems to me that the space to open up conversation seems to be a real opportunity that stands in front of us, and that we should be grabbing that.
Thank you. Yeah, thanks. Just Dr. Rafa, CEO, questions from last time. Whether there are any recommendations regarding concentration at local level. He's no longer here. Okay, no, but the point is, it's not all in one place. It's about, for example, schemes are already allowed to have regional schemes, as it were. The licenses tries to deal with that, and a lot of the recommendations around HPCSA enabling multidisciplinary practices can be seen to look at that. Mr. Khabane, regarding the relationships that we see with the regulator, yeah, there are quite a few relationships that we see with the supply side regulator. For example, one of the arms would be for economic value assessments, and that's otherwise known as health technology assessment. And we see this, the South African Health Products Regulatory Authority being in a close working relationship with that, which obviously we do know they say this medicine, this product is safe to use, and what we're seeing the regulator is to say that may be so, but is it cost effective? And the main thing is that those results will be published so that we introduce pressure into the sector. And I see smaller players might benefit. They no longer have to invest in expensive exercise if they can leverage off the research of the regulator. The pricing unit will work closely with the CMS for obvious reasons. pricing, again, we feel has to be on the supply side regulator, because if the CMS were to determine the prices of services, then there's a conflict situation because they really represent payers. But the relationship is close with the HPCSA as well, because remember the guidelines that we are, or rather tariffs that we are suggesting, at some point, the ethical billing practices comes in. Where is the cutoff? We're recommending that the regulator works closely with the HPCSA to determine those policies up front so that they are clearly understood. And key to that is informed consent. I've left the OHSC last because it probably will have very, very close relationship with the regulator. Actually, so close we don't see why ultimately it shouldn't be incorporated into the regulator. Remember that there's the issue of the licensing of hospitals, where right now they're focusing on public. We don't see any reason why further on there wouldn't be, and we understand there's the plan for private as well. I think the major extension is to say they should be responsible for the private or the primary healthcare facilities as well, GPs practices, and you can see the alignment there. So in terms of interim implementation, certainly we flagged pricing as an urgent one that can't wait for all the regulatory legislative changes that must happen before we have a supply side regulation. Forgotten which ones as well, but we did flag some that are urgent. Regarding the minister's questions, I think this will be linked to Mr. Makubele's. Regarding the centralization, standardization, we start from the perspective that healthcare is a human right and it's regulated. The one country that probably doesn't is the United States, and you can see what health are. So it cannot just be left to the market. That's what we believe. But also, whether one likes it or not, the reality is that the Minister of Health is the custodian of health, both public and private. But what we try to do is to introduce the independence. And we looked at the OECD, and this is how this body is supposed to work. And we have already said it's not about it being independent from the minister, but it must be independent from the private sector as well. And on pricing, you heard the person or the entity with the last word is not the regulator, but is the independent regulator, for example, where the regulator made the pricing. Now, so on efficiency, ultimately, it's about whether the independence will be there and the caliber of people that we suggest should. That leads directly to the minister's question regarding who appoints. Our proposal is that there should be the regular public process of nomination of people, and then they are appointed, preferably through parliament. Main thing here is that it's the governing body that's up. From that perspective, the department should stay away and allow the governing to appoint its executive, including the CEO. And we're looking for professionals who are experienced and can run the institution. Regarding minister co-payments, it's always a problem when you're praised by the minister as a panel, I can tell you. Because and on co-payments, we're not with you. As far as PMPs are concerned, we do see a role for because the overutilization, an element of it is about healthcare being sought. And if co-payments are designed to channel to the right level, we don't have a problem with it. The main thing is that it shouldn't be that the alternative to paying co-payment is that you don't. The example I use is touchy issue of toll gates. If you want a 6-lane highway, then pay the co. But it should not be that there isn't a good quality road that isn't available to you. So that's how we see, it's just to simplify. And on the certificate of need, Judge went in detail in terms of saying, let's implement that. But what we done through the licensing process, you'll see we probably went further in terms of detail, but we're trying to nudge the regulators into getting far more intelligence as to where these establishments should be sited. Yeah, I think that covers Fontain's question as well. And relationships between hospitals and pathologists. No, you want to take that relationship? Okay, yeah, I think there's a whole section on relationships between providers and hospitals. And overall, we just say there are question marks regarding the relationships. There are too many incentives that are there, even though we couldn't find the smoke one. We looked at contracts, but this has to do with shares that are offered to practitioners. It has to do with free rental accommodation, even though with pathologists in particular and radiologists, they do not enjoy that benefit. They pay full value in terms of rent. Now, we certainly confirm that those two have driven expenditure, probably more than any other group, but there's nothing that we found that sort of says they are.
There is a pattern of ownership between particular pathology groups and particular hospital groups. But what was more interesting around the pathology groups was their ability to ignore a tender in the market. So a very large purchaser put out a tender call, and it seemed to us to be unusual that if you were a very large purchaser was putting out a tender, that you were secure enough in your marketplace not to respond. And that seemed to suggest to us that there was a problem in the pathology market. So that was one particular finding. In relation to providers in general, particularly for those service providers, so pathologists, radiologists, for example, are very quick to say, we only do what other doctors tell us. We never drive demand. And it's true, they only do. If I'm a doctor, I write a request, FBC, UNE, whatever it is, and then the pathology group does it. They don't drive it. But it seems to me that, again, this talks to the issue of quality and underlines why we think multidisciplinarity, as the rest of the world does it, as good standard of care should be followed, is that there are many times as an individual doctor that you don't have a big enough group of patients to know that every patient doesn't need an FBC and a UNE and a liver function test and whatever else you're ordering. But pathologists could group all their information, and they could say, for these kinds of people, actually, you just need an HB, and you don't need to do these 17 other tests. It's not cost effective, but most important, it's not increasing your knowledge in terms of healthcare. And so we feel that there are a lot of doctor groupings who could be getting together, and probably another group that haven't necessarily provided the guidance that they should is in the academic sector, is to say, here's the kinds of things when you have these kinds of patients, do these tests. Don't do more. You don't have to do an additional test. And it's also one of the recommendations to the HPCSA is to force the curriculum to change, to take these kinds of things into account. Teach doctors or other service providers, not just doctors, what things cost. And don't do things you don't have to do. Our argument, it's in fact unethical not to take the cost into account. And so there are various other recommendations that we haven't highlighted here that are also in the report that relate to these kinds of issues.
I just want to address one question that was raised in the previous round around late joiner penalties. We of the view that the late joiner penalties that that are imposed for people who are joining at 35 years or older do actually punish the young people who would have otherwise perhaps not have joined because of affordability issues. And as a consequence, we are then looking at other ways of incentivizing, whether it is through a discount in the premiums of young people who would like to join medical schemes. So that is covered in our recommendations. Thank you.
I just want to comment on two issues. The first one relates to the relationship between the regulatory body that we're recommending as against the other regulatory bodies provided for in the Act. We are acutely aware of the pitfalls of the proliferation of regulatory bodies with overlapping functions. And it is against that background then when we recommend, we make sure that functions of the statutory body that we recommend does not overlap with the functions of the already existing regulatory bodies. Second aspect that I would like to say something on is the certificate of needs. Now, the certificate of need, at least in this country and elsewhere in the world, in particular in the US, is not a new phenomenon. In this country, for example, you will recall that it was one of the major issues in the affordable medicine case, which concerns pharmaceuticals, where doctors who wanted to dispense medication had to obtain a certificate of need. Now, the reason why the certificate of need in that particular case was struck down, it was struck down because the Constitutional Court took the view that the purpose of the certificate was to shield other stakeholders from competition. The court did not consider the constitutionality of the certificate of it in itself. It was the way it was used which the court found unconstitutional. The one other issue that I need to talk to is the issue of price. Again, the issue of price regulation is not something that's new in this country. You will recall the case in the New Clinics, where there was a huge fight over the dispensing fee payable to pharmacists. What the state had done, it had set up a pricing committee which was responsible for determining fees payable to pharmacists. Again, in that case, the Constitutional did not strike down the very notion of price determination. But the problem was the process that had been followed by the committee in going about determining the price. Some of the questions that have been raised here go to the very heart of the relationship between competition law and policy on the one hand and the Constitution. The Minister of Health has a constitutional obligation under the Constitution to adopt measures that are necessary to enhance access to healthcare services. That's his obligation. That obligation carries with itself the primary responsibility as a national government to put out framework legislation. The National Health Act is that framework legislation. But it doesn't relieve the other spheres of government of that responsibility. They are supposed to work together and to cooperate in ensuring that the right of access to healthcare services is given effect to and that it is a reality. Part of the obligation of the state is to provide facility where citizens can access healthcare services. But it doesn't have to do it itself. It can get the private sector to intervene and provide those services. But when it does that, it has an obligation to make sure that the prices, whether they're being given by the state or the private sector, are affordable. That's what is required of them. And I think it is against that background that the role of the Department of Health must be understood in this relationship between competition, law and policy on the one hand, and the Constitution, bearing in mind that the Constitution is the supreme law and everything has to conform to it, including the competition law.
Thank you very much, Justice. Ladies and gentlemen, as we conclude, can I get an indication whether or not there are further questions from the media? Thank you very much. It's only Catherine, so okay, don't worry, we'll deal with it. Now I am advised that lunch is served at the restaurant, I think, on my right, but also parking coupons are also available on the exit, just on my extreme right. So, ladies and gentlemen, thank you very much for a fruitful exchange. We hope that you'll be able to engage with the report, give us feedback, and let me also remind you that the closing date for resubmissions for submissions is the 7th of September. So engage with the report and make sure that you then submit your response by the 7th of September. So on behalf of everybody, the panel led by the judge, the commission, and stakeholders led by the minister, thank you very much for your attendance. Thank you.